Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, it's Susan Kaufman, and you are listening to Attitude Magazine's ADHD Experts Audio. If what you're looking for is clear, unbiased information about ADHD diagnosis and treatment, both about the reality of ADHD today, as well as the societal forces that are pushing up the rates of diagnosis, then today's webinar featuring Dr. Stephen Hinshaw is a good one for you. Dr. Hinshaw's topic today is ADHD, everything you need to know about causes and treatments, and he will be talking about the genetic, the environmental, and the psychosocial factors that cause ADHD. He'll give us a great overview of the treatment options from behavior medicine to newer brain-based training options, and all in the context of trying to clear the air of the polarizing and often misleading information that abounds about attention deficit disorder. Stephen Hinshaw, Ph.D., is a great resource for us. He is a professor of psychology at the University of California, Berkeley, vice chair of psychiatry at the University of California, San Francisco. His broad work focuses on family relationships, intervention for children with ADHD, mental health problems, stigmatization of mental health, and much more. He's written 9 books, including the very recently published ADHD, What Everyone Needs to Know, which he co-authored with Catherine Ellison and was published by Oxford University Press just 5 weeks ago, and I urge you to take a look at it. It's clearly written, a great book, no footnotes, general introduction to ADHD that you can trust. Thank you so much for joining us today, Dr. Hinshaw. We're always happy to have you.
Thank you. Great.
Before I get started, let me just thank our sponsor today. We are so grateful to our sponsors. They allow us to do these very popular ADHD expert webinars weekly and to make them free and open to anyone who wants to log in. Our sponsor today is NEBA Health. That's NEBA Health. NEBA Health is a brainwave test. It's the first one cleared by the FDA that helps clinicians understand if a child's symptoms are due to ADHD or to another condition. NEBA Health's brainwave test is generally used along with a traditional diagnostic workup for ADHD, and it may help clinicians confirm the ADHD diagnosis or prompt them to look for other causes of a child's symptoms. So all in all, a helpful brainwave test. For more information, please go to their website. It's www.nebahealth.com. And I thank them again for that. So with that and our thanks, let me turn it over to Dr. Hinshaw.
Terrific. So we're going to learn everything you wanted to know about causes and treatments today. That's a lot to learn, and so I'll be talking quickly but expeditiously, I hope. So we're going to talk about some of the forces that cause ADHD, a brief overview of treatments. The big evidence-based treatments, of course, are medications and the wide class of behavioral and cognitive behavioral treatments, and we'll mention other newer and somewhat more controversial forms too, and then we'll get a number of questions from you and answers from me. The book, Susan just so kindly mentioned, just out in early November, ADHD, What Everyone Needs to Know. This is Oxford Press's What Everyone Needs to Know series. And Kathy Ellison and I were glad to contribute the first of this series in the mental health genre about ADHD. No footnotes, no references, question and answer format, easy to read, but we think definitive and authoritative information. So moving right along, ADHD continues to be in the news. In the United States, the National Survey of Children's Health, run by the Centers for Disease Control and Prevention with its ADHD supplemental questions, documented that parents tell us that between 2003 and 2012, 41% additional kids between the ages of 4 and 17 had received an ADHD diagnosis. So it's now, according to those parents in the national survey, 11% of all kids between 4 and 17 have been mentioned by a professional or diagnosed by a professional to parents as having ADHD. So the rate is going up fast. In previous webinars, I talked about some of the roots of that fast rise. We're going to talk more about causes and treatments today. The short story here is that very quick diagnostic assessments can and do lead to both overdiagnosis, because not all the factors are taken into account, but even underdiagnosis because the child's behavior or the adolescent's or adult's behavior in the natural environment isn't considered. And so to diagnose ADHD accurately takes some time and effort. In fact, the biggest increases now are young adults and middle-aged adults with ADHD, and in fact, women are the fastest growing segment of the population receiving ADHD medications these days. ADHD is still ridiculed and stigmatized. This would be the subject of a whole other webinar if we ever have the time to do another stigma-related one. And even the venerable New York Times, with its excellent portrayals of many other mental health conditions, is still highly stigmatizing in its Sunday review and opinion pieces about ADHD. Some of the noted authors and contributors to other fine features of the Times are mentioned here as writing pretty ridiculing accounts of ADHD. ADHD is controversial. We hear all the time about interesting, unusual, and wrong causes. SpongeBob SquarePants causes ADHD. Actual trials of young children show that watching erratic cartoons like SpongeBob can temporarily contribute to executive control problems, but this is obviously not the cause of ADHD. We'll mention diet as a treatment, but poor diet is not the cause of ADHD, nor is lax parenting, even though parenting can contribute to maintenance of symptoms, as we'll talk about. And of course, we all know that ADHD isn't real. It's just an excuse for gaining accommodations and gaming the system. There has been a run on accommodations and ADHD assessments, but with thorough diagnoses, which we need to enforce better and reimburse better, this would be far less of a problem. One of the big issues we'll cover a little bit in a few minutes in talking about medications is what's called diversion, the use of medications by people without ADHD to enhance performance. And this is a controversial topic that certainly fuels stigma as well. In truth, if you're a kid with bona fide ADHD, summing across all such kids, this is highly costly to the economy. Academically, behaviorally, the most recent estimates are that it's about $100 billion a year cost to the economy, not the direct costs of treatment, but the long-term cost offsets of special ed, juvenile justice, some of the outcomes linked to ADHD. And for adults, largely because of under and unemployment-related problems, that might be even double, $200 billion a year to the economy. Kids with ADHD tend to get rejected by their age mates more than kids with almost any other diagnosis of childhood. Kids with ADHD look like they can do it and should be doing it, but then sometimes their impulsivity gets in the way of their social performance, and peers are not happy with that inconsistency. As we'll talk about, families and parenting aren't the cause of ADHD, but they're contributing factors to maintaining the symptoms. Young kids with ADHD, teens with ADHD, adults with ADHD, whatever the age, there's a very high risk of accidental injury. Sometimes these can be fatal injuries, sometimes they can be disfiguring and impairing. ADHD is not just bothersome, fidgety behavior. It's quite dangerous with the impulse control problems related to it. Over time, the comorbid conditions, the associated diagnoses that go along with ADHD increase in severity by adolescence and adulthood: substance abuse, delinquency, depression, and particularly for girls, as our own research has shown, self-injurious behavior. Some contend that ADHD is a hidden gift. These traits really propel one to creativity. Well, I wish it were that simple. Certainly, there's been natural selection for some of the adaptive traits related to ADHD, but all too often in today's world, the symptoms yield impairments, and treatment is really important. ADHD, we diagnose yes or no, as we do for high blood pressure and many other conditions, but it's really continuously distributed. It's on a bell curve. The underlying symptom domains of inattention and disorganization on the one hand, hyperactivity, impulsivity on the other. The new approach touted by the National Institute of Mental Health is not the DSM, but the research domain criterion approach to look more dimensionally at these underlying traits and symptoms. Is ADHD an attention deficit? Well, that's interesting because there's multiple forms of attention. Maybe it's better characterized as an executive deficit or executive dysfunction. Planning, adjusting your expectations, correcting mistakes. These are the executive functions along with working memory, holding short bits of information in mind. There's a lot of evidence that many people with ADHD are deficient in some core executive functions, but there's many people with ADHD who seem to have adequate executive functions yet still suffer the symptoms. So maybe moving down the slide, it's not so much executive dysfunction as disinhibition. The kids who blow out the birthday candles at the party, but it's not their birthday party, it's their friends, because the temptation of that beautiful frosting and those lighted candles is too much, and the kids temporarily forget that, oh, the situation dictates that I shouldn't be the one blowing out the candle. So maybe it's inhibition and the lack thereof that leads to these executive deficits. An older model of ADHD, but one that's making a big comeback in terms of research, is about intrinsic motivation and reward. People with ADHD are often so-called hyperactive, but inside their brains, there may be some deficiencies in the transmission with the neurotransmitter dopamine, which leads to a more sluggish, under-aroused neural system, and some of the fidgeting may be, in fact, an attempt to keep alert and keep awake. And it may be that because of these dopamine deficiencies and reward pathways, people with ADHD have particular troubles developing a sense of intrinsic motivation. This is why reward programs are so helpful in terms of treatment. Our colleague over in the United Kingdom, Edmund Sonaga-Bark, talks about dual and triple pathway models that for ADHD that might involve executive functions and or inhibitory problems and or motivational problems. ADHD symptoms are embedded deep in our DNA. The heritability of ADHD, why I'm very distracted and hyperactive and you're very focused. The differences between us in these symptoms are largely differences in our genes, not in the environments we experience. 75 to 80% of those individual differences are controlled by genes. But this doesn't mean that you're born with certain ADHD genes and you're that way forever. The genes for ADHD, it's turning out, are very similar to the genes for other forms of mental illness. It may be that early experience shapes the particular ADHD symptomatology that some people get. Just because symptoms have a high genetic liability doesn't mean that they're immutable. If we had time, we'd go into examples of height. Everybody's taller, even though height's highly heritable, and other conditions like intelligence and PKU, where genes play a big role, but environmental change can lift most of the population to different kinds of performance. But what's the real cause of ADHD? Somewhat tongue-in-cheek, I've contended that the real cause is this thing called compulsory education. Once, about 150 years ago, United States and Western Europe, and then of course other countries too now, made all children sit still and learn in school. This was the revealer of the 5 to 7% of the population whose genes predispose them to disinhibition, fidgeting, inattention, so that it's no coincidence that clinicians started writing and talking about ADHD right around the time of compulsory education. So it's really conceivable that ADHD has roots in genes and biology, and as the culture has shifted to high demands for academic performance, it's little surprise that rates of ADHD diagnoses have been increasing. Very briefly, there's other biological factors, not just genes per se, that also contribute to ADHD. Being born at very or extremely low birth weight, just a couple of pounds rather than the cutoff of 5.5 pounds, predisposes to a range of movement and learning disorders, including ADHD. Teratogens are substances a pregnant mother ingests that lead to physical and behavioral malformations inside the child. Fetal alcohol effects, not full fetal alcohol syndrome, but fetal alcohol effects mimic the symptoms of ADHD. Maternal smoking during pregnancy is also linked to later ADHD and oppositionality. Some of that may be a genetic link between mother and child, some the actual effect of the toxins inside cigarette smoke. There's been evidence for 40 years that environmental lead can mimic ADHD symptoms. More recent evidence, still to be proven, that pesticides, flame retardants, exposure early in development might also mold the brain toward ADHD symptoms. The stereotype is that bad parenting causes ADHD. There's no consistent evidence that this is the case. But as we'll discuss in a moment, fighting fire with fire, having that temperamentally difficult and sometimes defiant child, and responding with harsh and sometimes too lax parenting can fuel the symptoms. The message from this slide is that genes and other early biological experiences work together with experience to create the symptom pattern known as ADHD. A given outcome, like ADHD, might in one case be linked to genes, in another case to fetal alcohol, in another case to being raised in a horribly deprived Eastern European orphanage or institution. One of the outcomes of kids like that is very severe inattention and hyperactivity. This is what we call equifinality. There may be very different causes that all lead to the same condition. ADHD is not one disorder or disease. It's probably many with similar symptoms. By the other side of the coin, multifinality says that a cause or a condition like ADHD might yield very different outcomes depending on parenting and schooling and all of the contextual factors. So the more we learn about psychopathology, even though genes play a decided role, things are not fixed. Environment and context are crucial. What about parenting? As I've been suggesting, it seems to be much more of a maintaining factor or cause than a primary cause. Genes passed between parent and child are pretty crucial for the symptoms, but parents who have shared symptoms with those kids and fight fire with fire may be pouring a little gasoline on that flame, and this is why parent management is such an important part of behavioral intervention. Coercion is a discipline style that mixes letting the kid go for too long and then coming down very harshly, and it's that coercive cycle of discipline that's the goal of most behavioral parent training interventions. So, throughout the history of psychological studies, two main dimensions of parenting have been identified. One is warmth and responsiveness, that's on our horizontal or x-axis, and the other is limit setting and control. The ideal in most respects is to blend high warmth with fairly high demands and control and limit setting, what's called authoritative parenting. Unlike high warmth but low limits, permissive, go to the flip side, over in the upper left, authoritarian, not so warm but fairly demanding and controlling, and then uninvolved all the way to neglectful parenting where there's low warmth and low control. Let's go into treatment. Many things are touted as treatments for ADHD, but there's really only two broad categories of treatment that have a clear, definitive evidentiary base. One is medications, often stimulants, other noradrenergic pills have now been shown to be evidence-based as well. And the other is the wide category of what are called behavioral treatments. These can be reward-based programs for kids, often taught to parents and teachers. And for late adolescents and young adults, there's increasing evidence that CBT, cognitive behavior therapy, challenging thinking patterns, doing specific training and time management, add to these reward-based programs, and CBT is now an evidence-based treatment for adolescents and adults with ADHD. What about just a few of the many? Neurofeedback, or EEG biofeedback. Seems promising. You learn to control your brain waves through sitting in front of a computer screen, and screen turns a nice mild color when your waves are in focus. definitive studies are still ongoing right now. It's not entirely clear that neurofeedback is better than a placebo or a sham neurofeedback where the person's hooked up to the wires and looking at the screen change, but the screen change is not contingent upon the person's brainwaves changing. So this has been true in other aspects of medicine. Biofeedback and neurofeedback seem initially promising, but we don't know how much this is just a high expectation as opposed to a specific treatment yet. Diet was thought decades ago to be essential for ADHD. The Feingold diet out here in California, controlled studies showed that only a small percentage of kids really responded to this additive-free diet. More recent research in the last 10 years shows that, especially for kids 10 and under, it's not the sugar. Seems as though it is, but it's not. It's especially additives and dyes in foods may add a symptom or two to the 18 or so symptoms that are usually thought of as defining ADHD. So part of a holistic treatment may involve some dietary restrictions, but the effects are not nearly as strong as the medications and the behavioral treatments above. What about one-on-one therapy? Taking a kid to a therapist, doing play therapy, insight therapy might help for other conditions, but there's no consistent evidence that these treatments are effective for the symptoms of ADHD. In the last 10 years, there's been a lot of interest in what's called specific cognitive training, often in working memory. Training an individual, a kid or teen or adult, to hold on to more bits of information. Working memory is important for a lot of things we do in life. It's pretty clear now that we can train people with ADHD to increase their working memory by another digit in a digit span test, but it's not so clear at all that that specific training is really helping during homework or in soccer games or at home or for an adult at the workplace. The big question is, will these treatments generalize to the real world? So what about medications? What are the stimulants? Why would you give someone with ADHD who already appears sped up a stimulant? Well, a better name for these pills would be SDRIs or SDNRIs. What does that mean? We all know that an SSRI, a selective serotonin reuptake inhibitor, helps serotonin transmission in the brain. Stimulants are selective dopamine reuptake inhibitors. They block the molecule that reabsorbs dopamine back into the presynaptic nerve terminal, allows the dopamine to last longer. Some of these stimulants also do the same for norepinephrine as well as dopamine. So you get more enhanced focus and self-regulation while the medicine is in your bloodstream. Is there a paradoxical response? Is it that people with ADHD magically calm down on stimulants, but everybody else speeds up? Turns out to be pretty much of a myth. Most everyone will focus longer when they take a stimulant. That doesn't, however, mean that high rates of high schoolers and college students should be taking people with ADHD stimulant medications, because the risk of abuse when that happens is extremely high. If you really have ADHD after a careful diagnosis, there's good evidence that about 80% of the time, if you find the right exact formulation and the right dose, which is essential, you will improve in your ADHD symptoms. Only about 15% improve on placebo. So this is the biggest gap between active medication and placebo of any condition in all of psychiatry. Yes, you're not fidgeting as much, you're paying attention longer. Does it help your reading, writing, and arithmetic? Yes, but not fully. It's going to take other forms of intervention to teach skills, as we'll emphasize in just a couple of minutes. TES, treatment emergent symptoms, side effects. The biggest ones above placebo rates are in sleep, appetite, raising your heart rate a few beats a minute, and over the long haul, there may be, evidence is controversial, for kids who take stimulants pretty regularly, a potential loss of height of maybe an inch compared to your height potential, which means that this is part of the equation a family must think about in considering medication treatments for their kids. So what are behavioral interventions? Unlike most stereotype forms of therapy where you bring someone into the office and sit down on a chair or couch and talk to the doctor, behavioral interventions are really done in homes and in schools. sometimes in social skills groups or in summer camps, where the idea is to provide regular rewards and expected non-emotional negative contingencies. Goals are identified. If the child with ADHD is only reading for 2 minutes out of the 20-minute reading circle time, the goal next week is not 20 minutes, it's 3 to 4 minutes. You successively approximate and shape these skills. When parent management training is done with families, it's to be regular with rewards, regular with negative consequences, taking the emotion and shouting out of the picture. Procedures like a daily report card, where the teacher has some goals that the child should succeed at during the day. We'll give a check if the child has met those goals, and then that report card comes home in the backpack, and the points are added to the home reward system. You can flip this around so that school rewards are given for homework and home behavior too. Regular, consistent rewards. Remember, one of the theories of cause is that people with ADHD don't develop intrinsic motivation as well as or as fast as others, so these regular rewards are quite helpful. And as I mentioned a moment ago, CBT, cognitive behavior therapy for teens and adults, adds some self-talk strategies and explicit skill building in time management and organizational skills to the reward programs. So here's a slide from the MTA study in which I and many others participated a couple of decades ago. If you want to reduce the symptoms of ADHD fairly quickly and well, you get the individual on the right dosage of the right medication. But if you want to teach skills, so what this slide shows is, as the outcome, reduction of ADHD symptoms, reduction of aggressive symptoms, reduction of anxious and depressed symptoms, the 3 symptom classes, and teaching of reading and writing, and better parenting at home, and better social skills and friendships at school. It takes that dark purple line, the combination of the right dose of medicine with intensive home and school and summer behavior management. That's going to lead to the steepest declines and the biggest improvements in behavioral competence. It's rare to find a person with ADHD who magically responds to medication and that's all they need, especially for children who need academic and social skills, as my first content slide showed. Medication behavioral combinations are optimal most of the time. So what have we talked about in this brief review of treatments? Medications, if they're prescribed well and the dosage is right, often relieve some of the core ADHD symptoms. But it's going to take multimodal or combined treatment, behavioral or cognitive behavioral plus medication, to teach the competencies that are really the core of making a difference in the life of people with ADHD. And lest we forget, most people with ADHD don't just have ADHD. A lot of kids are aggressive or ornery or sometimes anxious. Adults can have Tourette's problems, or they can have depression problems. People of all ages with ADHD can have specific learning disabilities and issues. And those conditions are going to require treatments that aren't one and the same as stimulant or SNRI medications or strict behavior modification. They may take academic remediation, cognitive behavior therapy for depression or anxiety. So when we get into the real world of the complications that often accompany ADHD, multimodal treatment is almost mandatory. So I think we're going to go to question and answer.
Great. Thank you so much. That was really a great overview. Lots of questions here. I thought maybe we'd start with the ones about diagnosis. Can you perhaps start by giving us a brief overview of what you would recommend to those who are seeking an effective diagnosis? I think it's not so easy for parents.
That's right. And so let me start with a negative, not always the right thing to do. What you don't want to do is go and sit down with a pediatrician or a general practitioner for 10 minutes and say, the teachers are complaining, I think Johnny's got ADHD, or I think because of my workplace relationship issues I do, and 10 minutes later a prescription is written. The doctor,
and that's pretty commonly the way it happens, right?
all too commonly, we
Right.
don't have the right reimbursements in place. A lot of general practitioners and pediatricians aren't trained well. So at the very least, there's got to be a lot of discussion to get a thorough history for a child, birthing issues, milestones in infancy and toddlerhood, medical issues the kid has had, milestones in terms of social and language skills. For adults who may not have been diagnosed when they were younger, getting some historical information about some of the problems in school and in relationships that may not have ever led to a diagnosis but need to be documented. So that's number one, a lot of history. Number two, the doctor should be getting ratings for a child from parents and teachers about these exact symptoms of ADHD and other comorbid conditions. And the rating scale should have norms. They should have been delivered to thousands of kids of the same age around the country so that we can get an explicit comparison. Well, yeah, a lot of 4-year-old boys are pretty impulsive, but for this particular child, Jose, his scores are in the 98th percentile. There's really cause for concern here. So getting a thorough history, ruling in ADHD, ruling out many competing conditions, and getting rating scales, sometimes medical examination, neurological exam can be helpful, rule out seizure disorders. There's the whole issue of testing for cognitive styles, testing for achievement. Doesn't really rule in ADHD, but it might be very helpful in ruling out a learning disability or a comorbid learning condition. It's going to take, when we do our studies at Berkeley, we have the luxury of federally funded grants and 8 to 10 hours per child and family. No practice can afford that right now, but it's going to take a couple of times and getting good information to the clinician and a real considered team approach before that diagnosis is valid.
Wow. Yeah, it's tough. It's a tough one. There are a number of new tools out that assert. There's one here that I hadn't heard of that someone asked about. Assert to help with diagnosis. They're the ones that help define the medication, and there's other ones. Is there anything people should know about that's new in the field of diagnosing?
Well, so the good news is the brain science is proceeding apace, and we're getting closer and closer to the definitive brain scan that might show you have an ADHD brain and I don't.
Wow.
But there's a huge but here. Mm-hmm. While there's new things coming under the sun, ADHD is decidedly a low-tech diagnosis.
Okay.
There's no computer assessment. There's no brain scan that shows who does or does not have ADHD. Now, at a research scientific level, there do seem to be areas of the brain and pathways in the brain that show differences between typically developing kids and those with ADHD. But in any given case, because, remember, of equifinality, these multiple causal factors, it may lead to a false positive or a false negative. So just because you have certain regions of the brain that look suspicious on the brain scan doesn't mean you have the symptoms, and many people with the symptoms don't have those particular brain regions involved. There's no blood test. There's no objective computerized assessment. And remember, all of the computerized assessments of attention, the individual sitting, usually in the clinician's office, one-on-one under ideal learning conditions. What would be great is to get these individualized computerized assessments done in classrooms with the distraction and the 1-on-30 situation. That's the real world. So there's good new information coming in. The research journals, the scientific literature is advancing every year, but we're still far from that one-on-one blood test or brain scan. It takes getting the history, getting the ratings, synthesizing the information to make a diagnosis. And I think that's going to be the case for the next several decades at least.
Wow. I guess what that means is that there's someone that's asking a question here that I've heard before. How do I know definitively for sure that this is ADHD? So I guess if there's no blood test or individual test, then we're basically saying you trust your the person, the clinician you're seeing, right?
You're trusting the clinician who's doing evidence-based procedures. So it's quite similar to major depression. This is a huge public health issue around the world.
Right.
Maybe you just have a sad personality. Maybe you've just experienced a lot of losses. When do I cross the border into major depression versus chronic sad mood? It's a judgment call, but making the diagnostic decision is crucial because depression so often can lead to suicidality and all kinds of impairments, even physical diseases. As we mentioned, ADHD, accidental injuries, social, vocational, academic impairments. It's important to get the preponderance of evidence to lead to the conclusion that ADHD is a darn likely diagnosis here.
Okay. And at the end of the day, the parents are going to have to trust that this is a good diagnosis. It makes sense based on everything that they're seeing and that the clinician says. For adults, there are a number of, increasingly we're seeing this on the Attitude webinars, a number of people who've been diagnosed with ADHD, in their 50s, 60s, even 70s. And many of them are asking, is it true that they have to have shown symptoms as a child? What is the current thinking on diagnosing later in life?
So the current
treating,
thinking,
for that matter,
and treating. So the current thinking is there's at least three facets. Number one, ADHD doesn't stop when you hit puberty. This is what I learned in grad school 3.5 decades ago. This can be a lifelong condition. Number two, most of the time, some would contend all of the time, even though there might not have been a diagnosis back at age 6, 8, 12, or whatever, there must have been impairing symptoms back then, even though nobody knew enough to call it ADHD, because you don't just wake up one day with ADHD unless you've been abusing certain drugs or had a head injury, etc.
Right.
But number three, there's some provocative longitudinal evidence coming from New Zealand, other places around the world that, especially for women, there may be in the 20s, 30s, and 40s and beyond many cases of what feels like real ADHD that didn't necessarily have pronounced childhood roots and origins. So ADHD is considered what's called a neurodevelopmental disorder. You see it in the first few years of life. Maybe for some individuals and some women that's not necessarily the case, but in the majority of cases it would be that there's got to be a history. So that's why the adult diagnostician needs to go back and get some records from school or talk to people who knew the person back in the day, so to speak, to try to document that childhood history.
And is it your understanding, Dr. Hinshaw, that adults, 50s, 60s, 70-year-olds may be treated with ADHD medications? Because that's the common question.
So we know from literally hundreds of studies with kids and from scores of studies with young and middle-aged adults that the medications, again, if the dosage is right, if it's the right pill, if it's monitored carefully, can be quite helpful. The clinical trials with older adults are much fewer and farther between, but there's increasing evidence that, yes, they can be effective. With the one caveat that, as I just finished telling my psychopharmacology grad students at Berkeley in our last class last week, for anyone who's in the aging part of the age span, your body and your liver and kidneys don't function quite as well when you get older, so dosage adjustments and watching out for side effects is particularly important for any medication you give, whether for psychiatric or biological, physical reasons, for any older adult. So the rule of thumb, a good clinician who's monitoring treatment carefully is particularly true for older adults with ADHD.
That makes sense. It's just sensitivities to all medications being exacerbated. Just before we leave diagnosis, question here, the person says, am I correct in understanding that there are no or few medical providers that have a specialty in ADHD?
So,
why, she says.
So, child and adolescent psychiatry is somewhat of an endangered species within psychiatry. Within pediatrics, developmental behavioral pediatrics, a specialty of pediatrics that really focuses on behavioral and emotional disorders, neurodevelopmental disorders. Many medical schools don't have this subspecialty within pediatrics. This is. I mean, you hear me sigh through the microphone here. This is a time when rates of diagnosis are increasing, when the disabilities associated with conditions like ADHD are increasingly known, we need more specialists trained than ever, and we just don't have them, which leads me to think that we need to revise medical school curricula overall, as well as clinical psychology and social work curricula, to really understand these conditions well. So the short answer to the question is there are, and this is why you ask your CHAD representative or other advocates in your community for who the trusted diagnosticians are. There are those people through either formal training or just informal apprenticeship who really become expert in these conditions, but they are somewhat few and far between, and you have to watch when you shop.
Right. Definitely speaking to local support groups, people in your community definitely makes sense, word of mouth. Yeah. I know there's sort of a movement. I know Dr. Dodson and other people who have put together programs to help train pediatricians and primary care physicians to have better knowledge of ADHD. Dr. Dodson's fond of saying that they, if they're lucky, got 10 minutes on ADHD in medical school.
I know. So, yeah. Dr. Jeff Epstein of Cincinnati Children's has been doing in Ohio and throughout the kind of near Midwest extensive work to try to get primary care docs and pediatricians much better trained, and we got a long way to go.
Yeah, Dr. Jeff Epstein.
Yes.
Yeah. Okay. Well, yeah. It's tough. Let's turn to treatment then. Lots of questions about treatment. On the medication front, one last diagnosis. It's a good one here.
Sure.
Are there still two diagnoses, ADD and ADHD, or do we really just now say ADHD with or without hyperactivity?
This is the alphabet soup. Join the confusion. If you're confused by this, I am too. So the name changed from hyperactivity or hyperkinesis back in 1980, 35 years ago, to ADD, attention deficit disorder, with or without hyperactivity. A few years later, it changed to ADHD, attention deficit hyperactivity disorder. Now you can have the presentation that's predominantly inattentive, or the presentation that's really both inattentive and impulsive and hyperactive. So the official name is now ADHD. ADD is sort of the older term that's still used, and sometimes it's the shorthand to mean attention deficit hyperactivity disorder, the inattentive form. So ADD, we should probably legislate out of the lexicon just so we're not confused anymore, but ADD and ADHD are often interchangeable, although ADD might refer only to this inattentive form. So if you're more confused now that I've spoken, I am too, but I think that's the answer.
Okay. I mean, we use ADHD at Attitude, even though just to make things easy, and
exactly,
and it means whatever range of symptoms you have. Yes,
that's right.
Can you talk a bit about Strattera and other non-stimulants versus why one's doctor might choose that non-stimulant versus a stimulant medication?
So the stimulants, as I was explaining, if we could just change the lexicon again, would be called SDRIs or SDNRIs. They really enhance the work of dopamine and the reward and the attentional centers of the brain. Yet SNRIs, selective noradrenergic reuptake inhibitors, also are effective, not quite as effective percentage as the stimulants, but much better than placebo, showing that norepinephrine is a neurotransmitter that also helps mediate self-regulation. Maybe not the specific attentional boost of the stimulants. So it may be, that somebody has side effects from the stimulants. No matter how early you taper the last dose, there's still sleep problems, or there may be appetite problems. And the SNRIs, the atomoxetines or Stratteras of the world, don't engender those side effects. Okay. Number two, for some adults, especially those who might have had or be at risk for any substance abuse history or problems, the stimulants have addictive properties because they boost dopamine quickly. And the SNRIs, the atomoxetine, Strattera, do not. And it may be that, again, remember equifinality. ADHD is one name, but it's probably got multiple causes. You and I, Susan, could have the exact same symptoms, but you respond to a stimulant and I don't. I need an SNRI. So this is why the clinician has to work carefully, trial and error, to see which medication at which dosage for the right person.
Okay. Right. I mean, we had a wonderful webinar with Lori Dupar last week or the week before, which I urge any of you to listen to on replay, in which she literally talked through just how to get pick the right medication at the right dose and at the right
Yep.
time. It was a
Yeah,
full hour.
I'm going very quickly on this, and that webinar would be fantastic. Yeah.
Right, because it's a big piece of work for parents or anyone, and it sounds like it's very much worth doing, but not to be taken lightly.
Yeah.
Tweaking the medications in that way. So a lot of interest in alternatives to medication. Brain training programs, brain balance. There's questions about specific ones, CogMed. Any comments on the brain training and the neurofeedbacks, I guess, or the differences between them?
So, neurofeedback refers generally to altering your brain waves, the EEG signals coming from your brain, and there's different classes of those. Some of them seem to be more linked to distractibility and others to really focused attention. So in neurofeedback, you are training your brain to stay more onto those more adaptive brain waves through sitting in front of a computer screen time after time and kind of learning to get sort of training that set of brain waves to get to that place of focus through feedback. But as I mentioned, it's not entirely clear yet whether such treatment is specifically effective for alleviating ADHD or is one huge placebo effect of, wow, I'm hooked up to this computer and I've got wires from the electrodes and on my scalp going into the machine. It must be working. We just don't know yet if it's more than a placebo effect. And even if it does help some individuals, which I'm sure it may, does the focus you get sitting in front of the computer in the clinician's office generalize out into the real world? This is the name of the game for all ADHD treatments. Now, some of the brain training, or it's sort of brain training is now the term, used to be called specific cognitive training, the CogMeds and the many other. How can you get a better working memory? Can you learn to hold more digits in your head, or spatially remember the placements of things on the screen? Because that may be, those are the kinds of skills that underlie schoolwork. We know that specific cognitive therapy and specific cognitive remediation, I guess, training can help with those specific skills. But what's totally unclear is whether that helps you with your homework and your social relationships day to day. Mm-hmm. Can we generalize from the clinician's office or the lab out into the real world? And right now, the published reviews of all the science show that that gap is still large. For my money and my effort for myself and my family, the evidence-based treatments backed by hundreds of studies are going to give you, on average, the biggest effects with the most chance of building those skills. It's not to say that alternative treatments don't work for any particular individual, and right. A lot of families would rather not go the medication route, but how much of this, I would challenge a lot of families, is stigma. Would you withhold medications for your child's seizure disorders or diabetes or cancer? But we feel differently about behavioral emotional disorders, and the evidence for the stimulants and the SNRIs and the other adrenergic pills is considerable. They may not be long-term cures. They need careful monitoring. Look for the evidence-based treatments before you jump to the alternatives, is my advice.
Okay. All right. Let's see. Here's a person who lives in a part of the world where ADHD diagnosis is not available. Is there a possibility of remote testing and diagnosis? Might be difficult.
There are so many initiatives now appropriately for global health.
Really?
We've got big problems in our country, as wealthy as it is, with Affordable Care Act and who's insured and who's not and who's getting good coverage. And if you go into third world countries, the burden of mental health is even bigger, with hardly any doctors or child or adult psychiatrists and very little access to these kinds of techniques of assessment that we talked about earlier in the webinar today. I don't know how good this sort of telehealth or telemedicine would be, but
Right.
I bet if the person goes online to centers in the United Kingdom, the United States, Western Europe, and Australia, China, there's a lot of interest in ADHD now, India. I don't know the particular location, but this is sort of one of the frontiers of medicine, but it's really worth pursuing.
That's interesting. Yeah, I'm sure that's happening. More medication questions. The writer has two children. One medication works terrifically. The other one, it doesn't work at all. Neither a stimulant, non-stimulant. Is it possible that means child number 2 does not have ADHD, but rather a learning disability or something else?
So that is a possibility, but it does not definitively mean that at all. Remember my geeky slide on equifinality. Mm-hmm. Different causes may lead to the same condition, even in the same family. Two siblings share on average 50% of their genes, and it may be that kid 1, who's really the good medication responder, has a different genotype and different kinds of genes processing neurotransmitters in the brain that really respond to medications, and child number 2 has equally severe and valid symptoms of ADHD, but it has a different underlying neurochemistry that yields those symptoms, and so it's going to take alternative treatments. Now, of course, there may be comorbid or differential learning problems that better explain it, but just because you don't respond to one of these medicines doesn't mean you don't have ADHD.
Okay. So similar question here. My 8-year-old daughter, we've tried a dozen different medications, both stimulants and non-stimulants. Nothing helps her focus. So I guess it's a similar issue.
And so remember, with about an 80% overall response rate with the right dose and the right medication, that's about 20% who don't respond. And that's lower than for most other conditions, depression, and we get 50 or 60% response rate for the antidepressants. So this family is going to really have to work on the behavioral treatments, on the learning style accommodations and approaches to really get this going right.
Okay. This is interesting. Here's a family that says her 8-year-old son had intensive cognitive therapy for 4 to 6 months with almost no results. And as soon as he was put on a stimulant medication, they saw massive improvement in focus and self-control. And she's wondering whether the costly therapy was a waste of money or whether she should continue it as a supplement to the medication. And like medication, is it possible the cognitive therapy just isn't for everyone?
Yeah, very good point. We sort of think of, well, you're a medication responder or not, and there's side effects. All forms of treatment people respond to or they don't. All forms of treatment have side effects. They're not as sort of overt as for medications. Mm-hmm. So another point about this is medication often, especially the stimulants, lead to pretty quick and sometimes dramatic behavior change, matter of hours or days. Behavioral and cognitive treatments may take weeks to show their effects. It may be that they're building skills while the symptoms still remain in place. It may not be a waste of time at all. Maybe this family's going to see, now that the medication has pretty dramatically improved the symptoms, maybe the cognitive therapy is going to build skills on top of that medication.
Oh, it's interesting. It may actually work. Rather than abandoning it, this may be the time to really hunker down on the cognitive behavior.
It may well be. This is one of the principles of combining treatments. You hope for a synergy, that the medicine gets your brain in better attunement, so to speak, and then the therapy teaches you the skills with that better prepared brain.
I think that was one of the points that you made very clearly that I took away strongly, was that, for best outcome, you will be combining treatments, whether those are medication plus cognitive therapy plus whatever, but that's a real, I think, important message.
And just to prolong that point for a second, even if you say, well, my kid responds to medication really well, but the kid's in school, the kid's got a peer group, the medication's helping the learning that's occurring in those natural environments. So it's always a combination of effects.
Okay. What do you think about this, something called Genocide or other genetic tests that help people choose a medication? This child has gone through 10 different medications, and they're wondering if one of those kinds of tests might help clarify.
Well, this is genomic medicine. This is personalized medicine. This is the promise of cancer treatments, that your genotype predicts that you respond to chemotherapy, but I don't, et cetera, et cetera. we're not there yet for ADHD or any form of mental illness. The new genetic studies are coming out. There was one in a major journal literally earlier this week showing that unlike what we thought a couple of decades ago, we're going to find the gene for autism, the gene for schizophrenia, the gene for ADHD. The genes that underlie these conditions are pretty similar. Mm-hmm. They're basic building block genes of the brain, and it's epigenetics, early experience, that shapes people on these multifinal pathways. So we're not there yet for pharmacogenomics for ADHD. I hope we get there someday.
That would be wonderful. Dr. Hinshaw, thank you so much. Great information. And don't forget Dr. Hinshaw's new book, ADHD, What Everyone Needs to Know. Thank you all so much.
Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.